Thank you for starting the recording. So today's agenda will include introductions and announcements, a didactic presentation on common herbal and vitamin supplements and drug interactions related to hepatitis C treatment by Dr. Clark Allen, 2 adult case presentations, some time for Q&A and closing remarks, as well as space for hot topics. As a quick reminder, please make sure that you have registered through Southeast Age Education and Training Center as well. They are our accrediting body. So not only do they have a lot of really wonderful resources, but also it'll be necessary to make sure that you have registered for this particular session so that you can get continuing education credit should you be interested. We'll talk more about that at the end as well. And I believe we can drop the link in the chat too. First, we want to start with some in-chat introductions and brief announcements. So before we get started, I'd like everyone to take a second to introduce yourself in the chat. Please introduce yourself with your name, your role, your organization, and whether or not this is your first ECHO session. I see a couple people introducing themselves. Wonderful. As we continue introductions, we are going to open up to hot topics. So this is your opportunity to ask really any hepatitis related questions that might be on your mind. So in order to kind of streamline this, first of all, we always welcome you to come off of mute and just speak up and ask your question. But if you would prefer, you can join via Menti. You can scan the QR code and join through your phone, or you can join online using the code off to the left. Either way, or like I said, don't ever hesitate to use the chat or just come off of mute and talk. We're always happy to encourage a discussion. Really much prefer it, actually, but we're happy to talk other ways as well. So we'll go ahead to the next slide so you can start sharing some of your hot topic questions. And again, you can join via menti.com. Across the top of the screen, you will see the code that you need if you would like to pose any questions. Thank you, Anastasia. She shared the link so you can click it directly as well. We will pause for a moment or two as we get some of those questions coming in. In the meantime, does anyone have questions that they would like to bring up? Okay, so I see one. When reviewing quantitative and qualitative viral load results, why does a detected qualitative result take precedence if the quantitative result is below the designated threshold? So does anybody want to take a stab at that answer before we pass it off to our SMEs? Right. Well, then I will open up to, I believe we have Dr. Chastain and Dr. Allen with us this afternoon. Do either of you want to give your thoughts on this?
This is a very intimidating question. This is very thoughtful. And so I'm going to take a shot at this, but partly because Dr. Allen's going to be probably sore from speaking since he's our presenter today, but just fill a gap. This is really important because I think for those who are not as familiar with some of the diagnostic tests, just want you to recognize is that when we're talking about viral loads, what we're talking about is hepatitis C virus polymerase chain reaction tests. Polymerase chain reaction tests typically amplify the signal of a virus or bacteria or other target by getting a very, very small piece of something that looks like either DNA or RNA, and then using that as a primer to actually promote uh, replication or duplication of that signal in a laboratory specimen. So you take the blood out of a patient, you pair it in detection machine, you pair it with a primer, and you actually see how much you can predict or estimate by under those specific conditions. You can get different type of results. You can get not detected whatsoever. You can get a certain amount that is actually done based on the number of cycles or now the times that test will actually run. And then we actually get a value that is actually produced that we read, whether it be 100,000, a million, 2 million. But sometimes there is a level at the laboratory test that we can detect a signal where that primer may attach, but not one that can be quantified, that it doesn't get to a certain number or a certain amount. And historically, we've got lots of experience with this with other viral diseases like HIV, where historically the quote unquote viral load for HIV used to be able to be detected down to 1,000. But if it was lower than that, we could only tell if it was there or not. Then it became 200, then 40, then 20 or 15. And so the sensitivity of our tests have improved over time. I think hepatitis C in a similar form of fashion is our tests have become much, much, much more sensitive to picking up very small amounts of detectable genetic material. And that is what actually will differentiate basically a patient who is detected, but it's less than 40 or less than 20 or less than 15, versus a patient who might have 100,000 or a million. The reason that we've also spoken in these type of settings is that why we qualitatively care about this test far more is that the quantitative results for hepatitis C often do not correlate with downstream prognosis. Whether you've got a little bit, a medium amount, a lot, the fact that you have it is the most important piece, and actually being treated for it. Typically, we can almost use qualitative aspects. That all being said, a very, very, very low amount should always make us wonder as whether there is the potential for a laboratory error of some kind. And so if a person has a detected but not otherwise able to quantify, and you don't have a lot of additional history, a lot of times it is reasonable to repeat that test. On the other hand, some patients might be in the midst of spontaneously clearing their infection or other aspects, so we have to sometimes clinically interpret that data. But that is coming from a non-laboratory clinician as far as the way I would interpret these tests and how I would frame these in my mind. Clark, any thoughts about that to follow up?
I don't think I could add anything better than that. The main thing I would say is looking at time as to when the value was drawn. Like, are they on treatment versus not? That was kind of what my question was when they were asking that question: is are we talking about during treatment or before treatment? As to when that quantitative versus qualitative is most important. That was what I was thinking about: is timing of when it was drawn versus before treatment, during treatment, or after treatment.
Yeah, and I think that segues a little bit into our next question too, which is there a time when providers should monitor viral loads for clearance versus initiating treatment? And I would think this could also be relevant for spontaneous clearance as well. But I open up the floor to others that want to talk about it. Any of our providers in attendance, I know a lot of you have seen spontaneous clearance as well as initiated treatment. Anybody want to speak to their perspective before we pass it back to Dr. Chastain and Dr. Allen? Right. Well, we might have a shy group today, but that's okay. There's lots more opportunities to talk. So, Dr. Allen, Dr. Chastain, either of you want to talk a little bit about timing related to these tests as well?
Yeah, I'll just say that this has been a moving target in the past. So if you rewind the clock to pre-direct acting antiviral therapies when we were treating with interferon and ribavirin, When patients had early infection, you knew they had early infection, sometimes people would try to actually prioritize treating people with acute hepatitis C because the cure rates were much better for interferon ribavirin in that acute window. However, then there was this period of time with the introduction of direct-acting antivirals that the therapy was quite effective and yet very, very expensive. And some patients had a lot of side effects with some of those early therapies. And so there was a period of time we shifted from prioritizing treating acute infection to actually watching acute infection to see if people would spontaneously clear their infection. Because if people had a chance of spontaneously clearing their infection, then you could avoid any unnecessary treatment. And so we went from prioritizing treating acute infection when we found it with interferon ribavirin to holding off on treatment until we were sure we had to treat since we had better therapies in the early direct-acting antiviral era. Now the pendulum has swung back again, that treating people with acute hepatitis C or chronic hepatitis C is recommended regardless of where they are in time frame. And part of that's actually now framed on we've got great therapies, they're highly effective, they're well tolerated, but also people who have recently gotten hepatitis C are also probably people who were exposed in some way and engaged in some type of risk behavior or risk factor. And those are actually the people who might be the most likely to transmit that to someone else. So acute hepatitis C, not only can we effectively treat it and with low burden of side effects and outcomes, but ultimately actually might be even more important to treat people with acute hepatitis C in that context. Is it wrong to wait? I wouldn't say it's wrong to wait because some people, if they presented after a discrete exposure 2 or 3 months ago, and you have a viral load that returned and it's detected, but so low that you can't measure a quantity, it may be reasonable to say, well, this person's already starting to spontaneously clear. I'm going to wait and I'm going to recheck labs on this person because I've got at least a signal that this person might be spontaneously clearing. And in my practice, those are sometimes cases where I hold off on treating when patients who I suspect have an early infection and I have evidence that they are in the midst of spontaneous clearance. Those patients still warrant close follow-up because you want to be absolutely sure that they do clear and don't warrant subsequent treatment. But you can also make a judgment and say, I've got this person in my clinic, they have a detectable hepatitis C viral load. I don't know what the future holds. I can get them on treatment. That would also be a reasonable strategy.
That's usually our strategy as well. There's only a time where I can think of where we actually had 2 points on a line where we had a viral load when they were seen in internal medicine clinic, and then they came to hepatitis C clinic, and we checked their viral load again because there was a time frame of gap, maybe 6 months or so, and they actually had a viral load that went from maybe 2.1 million all the way down to 340. Then that kind of raises the question, are they trying to clear it? It's also been a great amount of time since the 2 points, and we like to just monitor that patient and see if they were actively clearing it, or do we just need to go ahead and start treatment? So sometimes if we have 2 points on a line and we can see it's declining, that would be a time to decide if we want to just go ahead and start treatment, or maybe we should watch and wait. Depends on the patient, but more oftentimes than not, if we know the patient has potentially a loss to follow-up, we can go ahead and just start treatment and get them through the medicine before maybe social factors change and we're no longer able to see them or follow them up again to even know if they ever did clear. So like Dr. Chastain said, more oftentimes than not, we'd rather just go ahead and start the treatment just for risk of loss of follow-up later, and then we won't even know the outcome. So getting them on medication quicker is usually our best bet.
Thank you. So in the interest of time, I think we will go ahead and move forward with our slides and take the next 15 to 20 minutes to go through the didactic presentation by Dr. Allen. So I will pass it back to you.
All right. So today's topic, herbals and vitamin supplements interactions with hepatitis C treatment. This one was definitely a little bit more challenging as the only drug or only option that's listed in the hepatitis C guidelines is one agent, which we will cover as far as being a herbal. But everything else, I just kind of had to scour the internet just to see what was the most common agents out there, what were the most common herbals used, most common supplements, and kind of gather a list and then go through my process of looking through drug interactions using the various resources that we'll talk about in just a second. We can go ahead and go to the next slide. No conflicts of interest with this topic, no affiliation with any drug company or anything associated with hepatitis C treatment. So as far as objectives, we will talk a little bit about mechanisms of action, not too much because we don't want to get off in the weeds, but we will talk about it just briefly with an article I found. We also want to be able to look at the interactions that I did find between herbal products and supplements and ones that may be problematic or ones to steer clear of. And then once we've determined that, we want to make sure we have a correct course of action, whether we should stop the herbal medication or supplement, or we should require extra monitoring while they're on treatment. We'll talk about those things as they come about. Next slide. Also want to go over our abbreviations as we always do. These are the same as the last session, but for those who were not here, hepatitis C, HCV, then we've got the 3 drugs that are used as the primary initial treatments for hepatitis C: gacapavir, pibrentasvir, trade name Mavorite; modipizir, sofosbuvir, trade name Harboni; and sofosbuvir, velpatasvir, trade name Epclusa. So GP, lead, soft, and then soft vel will be on the charts. Next slide. Then we can go ahead and go to the next slide. And this is going to be a look at the guidelines. We always want to make sure we're posting this to kind of establish what our standard is of looking at drug interactions. We always want to make sure we're looking at the patient's entire medication list before we initiate treatment, because there can be some potential for drug interactions. So we want to make sure we get their entire list, and that includes over-the-counter products, which is what we're mainly talking about today, to know if there's a potential for drug interactions. Do we need to modify something with that agent, or do we need to do something? Is there something else that we might need to change? More oftentimes than not, I'll say guaranteed, nothing will change with the hepatitis C medication. It's going to be everything else is going to be modified to accommodate the hepatitis C medication, just because there's very limited strengths and there's a very limited time that we're going to be on it. So we try to modify everything around that just to make sure it is nice and tidy while we're on the treatment course. Next slide. These are the drug interaction resources that I like to use. So I like to use 2 of them. I like to compare notes between the 2, and then I kind of make a clinical judgment if there's going to be conflicts between the 2. The one on the left, the University of Liverpool Drug Interactions tool, it's a free tool. It's a great option for anyone who doesn't have a subscription to Lexicomp or Micromedics. So that's kind of the downside of the 2 on the right. Lexicomp and Micromedics do have a subscription required, whereas the Liverpool interaction is free. So I use Lexicomp and University of Liverpool and compare notes just to see if there's any distinction or differences between the 2, and kind of go from there. And I would like to read into the kind of the text if there's an issue with the agents, and kind of make my clinical decision of what is the best course of action for the patient. Next slide. So to start off, before we talk about any of the herbal agents or the supplements, this is just what I found on the internet. So I'm not promoting any of these herbal uses. I just know that these are the most common ones that are used by the American public, maybe in other parts of the world as well. These are the ones that popped up the most. And so I had to try to make as big a list as possible without going crazy. So if you see one that you've never heard of, don't worry about it. I just tried to make sure I was all encompassing as possible without going too much overboard with it. Next slide. So this is the article I was talking about. I wanted to see what I could find as far as pharmacokinetics or metabolism of herbal medications. So the administration of herbal medications, it follows pharmacokinetic principles just like any medication you're going to take by mouth. So that includes absorption, distribution, metabolism, and excretion. And mainly we're going to be talking or worrying about metabolism. Reading through this article, it's an article that was posted in Asia, but it still talked about the principles of what these herbals can do from a mechanism standpoint in their metabolism process. They can sometimes, as we've talked about in the past, fooling with the CYP cytochrome P450 mechanism that is involved with a lot of medications that are metabolized through that process. So the thing with herbals is sometimes we don't always have that evidence, and we don't always have clear data to go by on what herbals are causing as far as drug interactions, what they are either inducing to the cytochrome P450 process of drug metabolism, or maybe they're inhibiting it. So it can be slowing it down or speeding it up, or it could not even be involved with the cytochrome P450 process, which is the main point that we're worried about with hepatitis C medications. They are metabolized through that process, and that's what we're most concerned about. After reading this article, most of the medications were not in America, but the principles are still the same as to knowing that herbals aren't as well studied as we do for medications that are prescriptions, because we just have a more rigorous process to work through to know about prescription medications. We understand how their metabolism. Herbal medications, not as much. So after reading this article, I was really more on the side of wanting to just maybe monitor or maybe hold off on herbal medications that I'm not comfortable with or not sure about. But I say all that to say this. On the next slide, you'll see that most of the herbal medications have been shown to be safe in Lexicomp and the University of Liverpool interaction, but it's still in the back of my mind that if I don't really understand the mechanism of these herbals and I'm not confident and I don't know if they are or are not going through the cytochrome P450 metabolism process like the hepatitis C medications, I may be more weary or concerned or cautious to maybe hold that medication, or can we hold it while we're on the hep C drug? So that would be a conversation case by case basis with the patient from that aspect. So I definitely want to put that out there, just knowing that some herbals, we just don't have the full mechanism, and that's something that we should be cautious with anyone that you know is on a herbal medication. So that's all important to know what the patient's taking. So definitely jog the memory when you're doing a medication history. Talk about herbals, supplements, over the counters. Just try to jog their memory on maybe things that they don't even consider they're actually taking that would be considered a medicine that they might not. That's just to help to jog their memory. Next slide. So we're going to start off, we're going to split it up into herbals and supplements just to kind of keep it distinct. And we'll also keep it in alphabetical order just to, for the sake of my sanity, just to keep it in, just knowing where I'm at in the slides. So we got several here. Everything looks good as far as interactions. We've got several type of, I guess not necessarily flowers, but herbs. Ashwagandha is the most recent one that I've seen. I had to look up what it was for. It's used for stress relief and anxiety. I had to just wanted to understand the mechanism, and I had to look up the interaction because that's not something I've normally see in my clinic. Everything is no interactions there, but I was still a little weary about it, and so I told the patient, can we hold off on that? Just for the duration of the treatment course, they were okay with that. So it's a case by case basis. Even though we have evidence to show with the drug interactions checkers that it's a-okay, it was just something new to me. And when I see something new like that and I'm hesitant, I'll usually try to err on the side of caution and maybe ask them to hold that medication. Next slide. Several more here, burdock root, chamomile, cinnamon. I see a lot of patients, not a lot of patients, but some patients will use cinnamon for diabetes. There's other medications that are also different type of flowers, different type of berries. Ephedra at the bottom, I learned about that one. I had to kind of went off in the weeds on that one. It's also a medication that's an herbal medication in China that's called Ma Wang. And so I kind of went down a rabbit hole. Everything's okay, but it can be considered a risk of maybe causing something with the liver, but not necessarily an interaction with hepatitis C medications. So that's kind of what sparked me to go look at other medications. Are there herbal medications that may be associated with liver treatment or maybe could cause harm to the liver? So I did find some not hepatitis C, some herbal remedies that are associated with potentially leading to liver damage that did not show up causing interaction with the hepatitis C medication themselves. So I didn't have them listed, but Ma Wang was one of them, mistletoe, valerian root. I'm trying to think of the other one, kombucha and kava. So there's some medications that might be at risk of causing liver injury, but not necessarily cause risk with the hepatitis C medication. So with that, I would probably want to hold off if somebody was on Ma Wang or ephedra, just because I know there's a risk of it causing liver injury. I would want to hold off on one of those medications if I knew it was something that maybe be causing harm to the liver when we're trying to treat and cure of hepatitis C. I kind of have the same counseling points when I talk about alcohol with patients, is we don't want to be overindulging in alcohol while we're trying to treat and cure the liver hepatitis C. We don't need to be causing damage in a different direction or a different pathway while we're trying to help it. So that's kind of my 2 cents on other herbals that may be associated with liver injury, but not necessarily causing an interaction with hep C medications. Next slide. So we finally got something that's not all green. So we'll focus on the G's down here. Now, garlic, it said it was okay with all the medications. It does, when I ran through the interaction checker, it did say there was some conflict with the cytochrome P450 metabolism mechanism that all the hepatitis C medications work through, but it still said everything was okay. So I would kind of just keep that in the back of my mind that if a patient's taking garlic for a reason, maybe see if they can hold off on that one. Ginger and ginkgo biloba did flag, saying that there's some induction associated with the cytochrome P450 process, and there's some potential weak inhibition. I'm more concerned about the induction or the inducing or the speeding up metabolism of the medication. So those are ones that it said they were weak, But that's why I wanted to put a monitoring. It's not something that is considered a strong inducer, but it does show that there is a weak possibility it can induce metabolism of that process. So therefore, I put just monitoring. Potentially, you could have the patient come off of that medication if you felt more comfortable. So everything on the graphics is strictly what the interaction checker said. And then I wanted to make sure I add my 2 cents about what I thought as well. The other thing before I go to the next slide, the Lexicomp and University of Liverpool, Lexicomp had everything that I've listed here. University of Liverpool didn't have all of the herbals that I was expecting, so it didn't have all of these. So most of these medications you'll see was only able to get evidence from Lexicomp. So if you go to University of Liverpool and you're not able to find all these, just refer back to this lecture and if you don't have a prescription to Lexicomp, just refer back to this lecture and that'll give you kind of some guidance. Or you can just reach out to me. I'll have my email at the end of the lecture as well. Next slide. We finally got some some contraindicated medications here, and we'll talk about it because I know some people might be upset and frustrated by that. But we want to talk about grapefruit juice first. That is also one that's been shown to have issue with the cytochrome P450 process. We call it a CYP3A4 inhibitor. It's not something that I'm concerned about causing issue with the metabolism because it's actually inhibiting, therefore it's going to increase the concentration of the medication. There hasn't been shown an issue where there's increased side effects or increased toxicity levels or adverse effects associated with inhibition of the 3A4 process when dealing with medications for hepatitis C. Now, that might not be the case with other medications, but with hepatitis C medications, it's just something we want to monitor for and just be aware of. Now, we want to get to green tea. So green tea had conflicting evidence between the two interactions. So I did a deep dive on that. Lexicomp actually had an issue with ledipasvir and sofosbuvir and sofosbuvir saying that there's a risk of induction there with the P-glycoprotein process. So that's just a different mechanism of how drug metabolism is processed through. So it showed that there was an induction there. And then I go over to the University of Liverpool, and it has the exact opposite. It has that there's no issue with trade name Harvoni, trade name Epclusa, but it had an issue with Glucaprevir, Prevensivir, trade name Maverick, for the same exact reason. So when I get conflicting data, that's usually when I kind of err on the side of caution and just want to counsel them how much green tea are they consuming, when do they consume it. Maybe it's something that they can maybe make sure that they split apart from when they're taking their Hep C medication. Because if they really like their green tea, that's fine. It just may be something we need to monitor or push to the side to a different time of the day. So it definitely at least 4 or 6 hours. That's not going to be anything in evidence, but something we just need to space them apart just to be on the safe side. If they want to drink their green tea, I'm going to be okay with that, but we just need to space it away from those just because we're getting evidence that there is some type of interaction there, potentially with induction of the hepatitis C medications. Next slide.
Yeah, that's fine.
So the first two, licorice, it was marked as a weak inducer of the CYP3A4, but it doesn't have any interactions flagging in the interaction checkers. So I was kind of bummed about that. I expected to see that because I had read in several articles while I was doing research for this that licorice was going to flag for that, and I was kind of disappointed that it didn't flag. So I just wanted to definitely give you that nugget. If somebody's on licorice for whatever reason, this is not necessarily the candy. This is more of the plant or the herb. So I want to make that clarification as well. Milk thistle, it is shown to have varying. It can be inhibitory and inhibition and induction of different CYP pathways. And so I put a monitoring there. It still said it was weak and it didn't have any contraindication. So if they're on milk thistle, I'm probably going to recommend they come off of that too. But this is what Lexicomp preferred, just to say monitor. I'm more on the side of if it's going to be inhibition and induction, I kind of get worried about that. I would probably just say, hey, can we hold off on that for the time being? It's only going to be for 12 weeks, and then we can restart that if you want to be on that medication. So sometimes I want to err on the side of caution, and that's what's important about the drug interaction checkers is read what the data is saying in the little box. You can always, when there's an interaction that pops up, you can click on the kind of just the link and it'll give you kind of an explanation. Most of the explanations are going to say it's not been studied well. That was a common theme because most of these medications haven't been studied in depth, and I expect that. But just trying to get some type of information, if somebody's done any type of research, just to get some type of knowledge about if there's going to be a potential interaction. If there is, if it flags at all, I'm more wanting to err on the side of caution for that. Red yeast rice, that was a fun one because that's actually one of the initial components of lovastatin. So it's a very small amount of lovastatin in red yeast rice. And so if we remember way back to when I did my initial drug interactions, I guess that was June of last year, I think. Glucaphor, Bernsphere, trade name Maverick, does not work well, or it's contraindicated with lovastatin because it just shows that there's increased risk of muscle pains and potential for rhabdomyolysis. That is not the same case with trade name Harvoni, trade name Epclusa. Next slide. So that, oh yeah, we got one more slide. I thought that was going to be the end of the herbals. We got one more slide. Got some interesting ones here. Slippery elm. It didn't have any issues, but I wanted to read more about that one. I'd never heard of that, so I wanted to kind of learn more about that one. It does have interesting properties of a sticky, viscous substance, and they said there's a potential that it could slow down metabolism of a medication. So I thought that was interesting. Not to say that I'm worried about the hepatitis C medication. I might be okay with that one. But it was interesting to learn about how it works. Just to know that it's kind of a sticky substance that potentially slow down drug metabolism. I thought that was interesting. And then what we've all expected, the one medication that actually is listed in the hepatitis C guidelines, St. John's wort, it is a strong inducer of the CYP3A4 pathway as well as CYP2C19 and CYP2C9. It induces that pathway, therefore it's going to induce or increase the metabolism rate of the hepatitis C medication. Therefore, it's going to cause major issues with getting adequate therapeutic levels of the drug to be effective at curing hepatitis C. So if you see that somebody's on St. John's wort, they need to stop that while we're going to be on hepatitis C treatment, as well as a number of other medications. It flags with many medications. So you're probably not going to see that many people on St. John's wort. I've yet to see somebody, but if you ever see somebody and you're trying to treat hepatitis C, we gotta hold that just for the safety of the hepatitis C medication. And then, as I said, I think I talked about valerian root. Valerian root is fine for hepatitis C medications, but there is a concern that it could cause liver injury. So that was one of those agents that I listed before. So no drug interaction, but there is a potential for liver injury. And so I would probably want to ask the patient what they're using that for and what's their benefit from that. Kind of have a conversation about that if they want to continue that. All right, next slide. So that concludes our herbal kind of medications. Any questions that we have about any herbals? Did you see, or was there herbals that you know about that weren't listed? I can more than happy look at other medications. I might have to just pull it up on the side here to see if there's any other interactions with maybe something that was missed or not included in the slide set so far.
You all can come off of mute, ask your questions, put them in the chat, or share them in Menti. But while you are adding your questions, I'll just say I found this didactic fascinating because I've heard patients bring up several of these different kind of herbal medications, and it's just a good reminder to really ask about supplements and herbal medications and sometimes explicitly ask about them, because I know I've had some patients where they don't mention it until you're starting to talk about hepatitis C more in depth, and then they're like, oh, actually that does apply to me. So really interesting and great reminder. I think I see one question. Are apple cider vinegar tablets contraindicated in any way? Please forgive if they were already shown and I missed it.
I don't think I included that. I'm trying to think. Yeah, I can run a check on that. I don't even know if that will actually have an option. 1 second if that will be listed in Lexicomp or University of Liverpool. Let's see. Okay. All right. It's actually going to have it in Lexicomp, and then I'll try the University of Liverpool second. All right, no interaction with apple cider vinegar in Lexicomp. And then 1 second, and I'll see if it's listed in the University of Liverpool.
So while we're looking that up, in the interest of time, Melissa, if you want to switch back to our slide deck, I think we can get ready for the next piece so that we can dive into our case presentation here.
Yeah, because we do have two. So yeah, I want to hurry up and get this. I can go ahead and talk about most supplements do not have any interactions, which is good. The one I wanted to point out here, calcium supplements versus calcium carbonate. So calcium supplements, so that includes acetate, gluconate, all the different salts of calcium are all okay, except for calcium carbonate, which is antacids. So any type of medication that's going to be labeled an acid to help out with heartburn, that's going to flag with ledipasir, sofosbuvir, and sofosbuvir. There's an issue with the acid dependency of two of the medications in the trade name Harvoni, trade name Eclusa. It's the NS5A portion, which is ledipasir and velpatasvir. Those need the acid dependent environment in the stomach to get absorbed correctly. So just think, if you are increasing the pH, therefore decreasing the acid, you're going to not have it as an acidic environment, and therefore potential not going to get absorbed correctly. So I tell patients just hold off on it if they can. If they can't, I give them the rules that you need to space the Tums or the Rolaids or the Alka-Seltzer. All those medications that have calcium carbonate in them need to be spaced out at least 4 hours on either side. So before or after when you take your trade name Harvoni, trade name Eclusa. No issue with Glucocaprofenprisvir. It does also have an NS5A component, but it does not have the same restrictions that it does for acid suppressant agents like calcium carbonate, H2 blockers, and proton pump inhibitors. Next slide. No issues here. More supplements here. Magnesium, tryptophan, lactobacillus acidophilus. And then the main kicker here is magnesium carbonate, which we just said calcium carbonate. That's going to be considered an acid. Now, magnesium oxide, that was the one that was kind of new to me, that I consider magnesium oxide the main supplement that you'll see for magnesium. But upon running it through the interaction checker, it flagged as being listed as an acid. And I was like, oh, that's new. So I kind of did some research on it. And so that's one it's listed as an acid. So that's going to be one that we want to consider either moving away from when they administer the medication just for safety reasons. I'm not sure how strong of an antacid it is, magnesium oxide specifically, but that would be one that we want to just separate from the ledipasir, sofosbuvir, and sulfoxafil velpatasvir. So that was a new one for me. So definitely counsel or think about that if they're taking a magnesium supplement. That would be one to be aware of, just because it is considered a acid suppressant or an acid. Next slide. And then we got some more elements, and then other over-the-counter products: manganese, melatonin, omega-3 fatty acids, potassium, selenium. Those are all okay. Probiotics, all those are okay. No interactions with any of the hepatitis C medications. Next slide. And then we've got all the vitamins, so vitamin A, B, C, D, E, and K. And then I've listed all the B vitamins out. I went through every single one of them just to make sure each B vitamin was okay. So that's why I listed all of them out. Zinc is fine. Whey protein is fine. No issues with interactions with those medications. And then so here is, if you have any questions, especially after the lecture, if you come across an interaction that you're not sure about, or you're getting conflicting data when you do an interaction and want to reach out, be sure to just write my email down and we can check on that together. I can definitely pull up what I have in my interaction checker. If you don't have a prescription to Lexicomp and it's not showing up in the University of Liverpool, just reach out and we can talk about that. I'm pulling up apple cider vinegar in University of Liverpool as we speak, and it's not even finding apple, so it's probably not going to be listed there. So I'll just rule on the side of Lexicomp and saying it's okay without interaction. So good question about the apple cider vinegar capsules / tablets. All right, I think that concludes it. We want to make sure we got plenty of time for our patient cases. Any questions before we start the patient cases?
So I think I saw a question in the chat related to ginger, but more specifically to diet. So if a diet involves a certain herb, do you recommend decreased use at least during treatment, such as ginger, which is often used in Asian food?
Yeah, I'd probably want to know how much as far as milligrams. I would go back and look more closely at what the interaction is. I actually don't have that it's a CYP inducer or inhibitor listed on my slides. I'll have to go back and look at that because, and that's one that I wasn't expecting. But there's always a time to learn. So I'm going to pull it up real quick in LexiComp and take a look. And so it actually doesn't even flag in LexiComp. So that means it flagged in University of Liverpool instead. Or at least I thought it did. And so now I've got to figure out, there was definitely, now I'm perplexed. If, let me get back to you on that, because I definitely had a reason for putting ginger and ginkgo biloba together, and I knew that there was monitoring. It might be from the article that I was citing. I may have to go back and find that article about what it was about ginger that was concerned about. Let me, you can direct message me and I can get your contact to kind of find that out. So let me get back. That's to be continued. Let me get back to you on that one.
Sounds great.